Good afternoon, one and all. Because of inadvertent reasons, Dr. Haripriya is unable to attend today. That is why I am presenting on her behalf. This is a presentation on retropupillary iris fixated IOLs. Iris fixation, as we all know, is a corrective technique for surgical aphakia. Sorry? He asked me to wait? So retropupillary iris claw IOLs as well as iris sutured IOLs have been described, and we can implement this procedure when we have intact iris integrity. And the contraindications, as we all know, are pigmented, neovascular, advanced glaucoma, low endothelial cell counts, and serious iris trauma or absence. Retrosuture iris fixation of a rigid intraocular lens has been described by us, published in the past in JCRS, but now we've come up with a modified iris fixation technique for foldable 3-piece intraocular lens with your regular phacoemulsification incision of 2.8 millimeter size. So 3-piece lens is injected as usual, but now this time it's going to be injected completely into the anterior chamber, and then one by one the haptics are tucked below the pupillary plane behind the iris. So the important part to note is that while tucking the haptics, we need to keep the optic above the iris plane. A cyclodialysis spatula helps us to guard the optic from slipping behind the iris. Once the optic is above and both the haptics are beneath, the haptics can actually be seen well because of the bump in the iris, and then the iris fixation can be done as is routinely done in cases of sutured iris fixation. So this is a surgical video with a 2.8 mm incision. And you can see that this is a surgical aphakia with a pre-op large peripheral iridectomy done by the preliminary surgeon. The 3-piece sensor lens in this case, no financial interest. The lens is injected into the anterior chamber. A cyclodialysis spatula in the left hand as a second instrument guards the IOL from slipping behind the pupillary plane. Before injecting, it is important to constrict the pupil with pilocarpine. Now this trailing haptic is also inserted into the anterior chamber. All along, the cyclodialysis spatula guards the optic from slipping behind. Once the IOL is inside, we bring the trailing haptic closer to the wound, the optic haptic junction closer to the wound, and with the McPherson forceps, simply it is important to catch it near the optic haptic junction and slip the trailing haptic behind the iris in a simple flex and disengage motion. Once this is done, we need to get the haptics away from the PI so that the bite in the iris can be placed through a good zone of the iris. The IOL is placed in an appropriate way at say 12 and 6 o'clock position, and then the sutures are taken with 10-0 Prolene sutures, as is done routinely with iris fixation lens. So now the two, with a single bite through the cornea, the two arms of the Prolene suture are brought out through the side port incision, and multiple throws are taken to keep the IOL stable. So this works like a sling, and it's a very steady sling that keeps the haptic in place. The similar thing is done on the other side to fix the leading haptic. So the bite is taken with the 10-0 Prolene suture when the haptic is visible as a bump on the iris, and then the arms of the Prolene suture are brought out to the opposite side port. Once the suture fixation is done, the optic is now tucked in the retropupillary plane and the IOL is centered well. The knots are tied and the surgery is over. We have the similar, we can do it with a large incision. This is a Weil-Marchesani syndrome where the full microspherophakic lens is displaced into the anterior chamber. The lens is gently brought out and a complete anterior vitrectomy is done. And once the anterior vitrectomy is done, we need to constrict the pupil with pilocarpine. So once constricted, this is a rigid PMMA lens. Now in this case, because this is a large incision, a rigid lens is similarly placed inside the anterior chamber. And the lens is guarded with the use of a cyclodialysis spatula. So the suturing is done in a similar fashion as was shown in the previous case. I'll just skip to the next slide. So these are post-operative pictures. You can see that the IOLs are well centered, and you can see the iris fixation sutures as well. So the advantages being it is using the anterior segment approach. There are no special equipments or IOL needed. The foldable IOL can be used. The 3-piece lens can be used. Even we can refixate a lens which is displaced, bring it to the anterior chamber and refixate the lens as well. So in comparison with SF-IOL, also there have been studies which have shown that iris fixation is quite a stable procedure with even lesser complications. To conclude, iris fixation IOL is an efficient and safe technique for treatment of surgical aphakia and subluxation of IOL in patients with inadequate capsular support. Thank you.
Thank you.
It's not working. So what we have to give the time for everybody will give the fixed time and fixed marks?
There is a timer working here, sir.
Oh.
We can't see. We can't see the...
No, I think they are buzzing the bell at the end of it. I request AV team to please take care
please
of
make
that.
sure that the timer is present on the screen also. Actually, sometimes when people are presenting with their own laptops, then timer gets lost. That's the only
Yes,
problem.
Subhashis, sir.
Yeah.
Dr. Seema, that
Yes.
was, I think, Haripriya's paper.
Yes.
You did well. But now we see we are not in favor of sutures. Even the scleral fixated ones are going sutureless.
Yes, absolutely.
How really will this be helpful in the future?
So the advantage here is basically you're using the same IOL that you have, to begin with. So we have done a study of 24 eyes in which 8 were done at the primary sitting. So when there was inadequate support, primarily we didn't have to change the lens. So that is one major advantage. And it's a complete anterior segment approach. So with a well-trained anterior segment surgeon, it can be manipulated without pars plana vitrectomy or without need for any other additional support. So in case of crisis, you can do well with it. Iris claw lens again is at a plane which is a little anterior, just snug to the back of the iris. So issues with glaucoma are probably higher with iris claw lens. A separate lens is needed. And the other thing is the IOL power also we can do with the same IOL power, because this acts as a sling and the plane is slightly posterior. We don't even have to change the IOL power. With the same PC IOL power, we can go ahead with the same power.
Okay, we understand that without a special inventory of special lenses,
Yes.
this is helpful. But maybe a longer follow-up is needed for that suture.
Yes, sir. In the cases that we have done with this particular technique, out of 21 eyes had 612 vision over a reasonably good follow-up of about 6 months to 1 year. And one patient had cystoid macular edema, which could be probably because of surgical aphakia also. 10-0 proline sutures, ma'am.
So proline is known to degrade over time, isn't it? Polypropylene is known to
So far, over a period of time that we have done the suture fixated IOLs, even with the rigid IOLs, our refixation rates or IOL drop rates as such have been close to zero. We've not had, there's only one patient, I think, to the best of my knowledge, that probably Dr. Haripriya will be better to talk about it. But yes, the rate of damage or the IOL slipping has been very, very low.
nylon. Have you tried 10-0 nylon?
I haven't tried it myself, but the tensile strength of 10-0 nylon is good, but for intraocular use, I'm not very sure. Yeah. The number of turns and whether it, it kind of stays without the loops with 10-0 nylon might be a little more difficult than with proline.
Yeah, but Haripriya has been doing this for more than 10-15 years.
Yes, with the rigid IOLs, and recently she's been doing it with the foldable IOLs as well.
I have a question on the technique.
Yes.
See, you're suturing the haptic when the pupil is in a cat's eye shape because your optic is anterior.
Yes.
Then you're putting the optic behind. Now, then the pupil is going back to its circular shape.
Yes, yes.
So, can these forces cause some kind of a cheese wiring? And if that's going to happen, is there any countermeasure for that?
So yes, what is recommended is that when we are taking the suture bite, it is important to take it in the mid periphery, not close to the pupillary margin, where the iris tissue is a little. When we are stretched the area close to there are two reasons. The area close to the pupillary margin is more stretched because of the IOL haptic. The area in the mid periphery to the periphery is a little more lax. That is one reason. And the second reason is we don't damage the sphincter, which is close to that may cause problem with dilatation.
Okay, so I had a suggestion.
Sure, sir.
What if when you're suturing, you put two hooks and again make the pupil circular?
A little more.
So then your torques are equal on both sides, and then
Yes.
release the hooks, put the optic behind, so that there won't be any misalignment of forces.
Sure, sir. We'll take that point. Thank you.
Thank you very much, sir. Sir, I just want to ask out of this question, quiz question, if any posterior segment complication, since it's a small pupil, then how are you going to, is there any ways
So
you are
that's
going
what
to
I was
handle
saying.
or
It is
we have to
important-
find an innovative way to do a retinal surgeries in these small
So we'll have you next time presenting in the Think Under the Apple Tree.
Thank you.
We want retinal
I request
innovation.
Anand sir and Kim sir and Samant sir to please look into the innovation of how to do retinal surgery in these small pupils.
Thank you very much.
Thank you,
Wonderful paper,
Ravisima. You can